Uh, Thank you, Rohit, for this invitation. Uh, Duane syndrome, as you know, it's a kind of, it compiles of all the strabismus. It's like if you see comitant, incomitant, vertical, everything, because they can come in different forms. So you need to know more of a strabismus to manage these kind of cases. As per the title, I have compiled some of the cases. I don't have a PowerPoint presentation to say that these are the management strategies. So let's start with the case one. This is the esotropic divan, typical presentation with the left face turn. You can see that there is retraction of the globe on adduction, and on abduction there is widening of palpebral fissure. So what you have, you can, I'm talking about only strabismus management here. We will not look into the optical as well as systemic. So what you can do here is just recess this medial rectus, and then you can give the alignment. How much to recess depends upon the deviation which is seen in the primary position. Either you can do a symmetrical or asymmetrical. So sometimes you might have to do the other eye also, especially if the deviation is more than 20 prism diopters. So this is a normal situation where you can do a simple medial rectus recession, which works very well. This is a patient coming with the head posture like this, and if you see a 9-gaze photograph, you can see that there is abduction limitation here as well as here. So this is a similar patient where there is esotropia in both eyes and there is bilateral esotropic Duane syndrome. Again, a simpler method is to do a medial rectus resection, which what we did, and you can see that by doing this, because these are all tight muscles, most of the times they will have a very tight muscles, you can see that even the abduction improves a little bit, even after doing a simple medial rectus recession. This is the pre and post operative abnormal head posture also gone for this child. So we looked at our series of bilateral esotropic Duane syndrome. What it comes to be is you have to do a medial rectus recession which is slightly more than what you do for routine comitant esotropia, most commonly what you do it for infantile esotropia. So this is a very basic, simpler management for this. And most of the patients come to you with the question that can we improve the abduction? This is where Dr. Crouch Johnston, he looked at many patients of Duane retraction syndrome with vertical rectus transposition, because that is one of the method to improve the abduction. And he saw the complications, like most of the patients coming with hypotropia to his clinic. So then he looked at, I think that's what is important. We need to look at our own results or our colleagues, patients who are coming to us, how much we can change the scenario. So he thought about for the first time that superior rectus alone can be transposed to the lateral rectus to improve the abduction. So that's why this is the patient with the large esotropia in the primary position, significant abduction limitation, and these are the 9-gaze photographs. You can see that there is abduction limitation as well as retraction. She had 30 prisms of esotropia in the primary position, and what we did is the same procedure of superior rectus transposition. This is the superotemporal approach. We are trying to anchor the superior rectus muscle and disinsert it, and then once you release it, transpose it to the lateral rectus along the spiral of Tillow and attach it to there, and also pass an augmented suture which is through the sclera. You can see at the end of the procedure we are using a non-absorbable suture around 8 millimeter behind that, and this is the procedure. Along with that, you need to do a medial rectus recession if the deviation is more than 15 prism diopters. And this is her primary position deviation after surgery, and this is her abduction improvement. So there will be a significant improvement in the abduction in all these patients. And she was ortho in the primary position as well as on the right gaze. And the left gaze, still there is a small amount of esotropia. My fellow Shailja is sitting in the audience. He compiled all these cases, and we in fact compared this medial rectus recession over a period of time. We have done till 2011, and we compared with the superior rectus transposition for esotropia. going to come in JAPOS in the coming months. So what it says is medial rectus recession both are effective in correcting the primary position deviation, but SRT has an additional advantage of improving the abduction by around 1.5 to 1.8 units. This is another case who is an old case of Duane syndrome, operated elsewhere with medial rectus recession. Probably the note says lateral rectus recession. You do this kind of situation for orthotropic Duane where there is a significant retraction. So this is a differential recession which is described. But for this amount of esotropia, I'm not sure whether they have done it. And obviously he is amblyopic in the other eye. And he comes to our clinic with the esotropia with the small hypertropia, and you can see that there is significant abduction limitation and there is a small amount of hypertropia. And in the operating room, we thought that the muscle is very, very, very tight. You can't even abduct the eye beyond even under anesthesia. So what we decided is to do a medial rectus recession. There was a small amount of medial rectus recession was done. We did 8 millimeter because we thought that it may not improve, and we did not do anything else at that point of time. In spite of doing 8 millimeter, you can see the adduction in this eye is quite good, and abduction did not improve, and there is significant widening as well as there is hypertropia, small hypertropia. He was not really happy, and we did not want to do a superior rectus transposition at the same time, and we did additional SRT with Foster's augmentation. He's much better. This is the I think 1 week post-op picture. He is happy, but I am not really 100% happy with the results. But over a period of time, his abduction improved with this. And this is the pre and post-operative picture where MR recession was done earlier. In spite of doing 8 millimeter with the SRT, it did not improve completely. This is another patient with. This is typically, the residents can tell me what is the diagnosis here. There is a lipoma here, 3 auricular attacks. And the patient comes with a small eye with the head tilt. This is the head tilt what he has. And his vision is counting fingers 1.5 meters here in the left eye. And this is the head tilt. And in the 9 gaze, what else you can see is there is even adduction limitation here also. So this is a bilateral exotropic kind of Duane. We wanted to look at the MRI because the ocular motility is a little bit unusual here. This is not the typical presentation of Duane's, and he had no abnormality. We were strongly thinking about a band, especially in the left eye, and he did not. He had a hypoplastic or aplastic superior rectus on the left side. Rest of the muscles were normal. So if you look at his optic nerve, the right eye is much bigger and the left eye. This is a common situation in congenital cranial dysanimation syndrome where they can have even optic nerve hypoplasia in one eye. So this is a known thing. That's what he had. This also showed that we wanted to rule out any other abnormal brain situation. So we did an asymmetrical, a very large lateral rectus recession on that side. Obviously the muscle was very, very, very tight on that side. So after this, this is where the situation, he did not improve much, but only thing is his head tilt improved. But in spite of doing that, because other option is to do a transposition procedure, but his superior rectus is almost aplastic. We can't even find the superior rectus there, and we can do just an inferior rectus transposition or make him to a sixth nerve palsy kind of situation and improve. And this is where it is. And the point here is, once you occlude this side, the head tilt is normal. So there is some contribution from supranuclear area, or there is some input going from this eye, which is a very poor vision eye. This is another unusual case. Luckily, he is orthotropic here. Again, inverse Duane's, which is congenital. On abduction, he has retraction of the globe, which is on both sides. So this is an inverse Duane, which is seen in acquired cases. We need to think of medial rectus cysticercosis, but this is there from birth. And what we offered him is the medial rectus Y split, but the patient did not want it, which is okay because he is absolutely doing very well here. So we did not do anything for this patient. Similar patient with a large inverse Duane syndrome with esotropia. You can see that on abduction, there is a retraction of the globe. This is where we did the medial rectus recession with Y-split. Still, I would not say that improvement in enophthalmos is not as much as lateral rectus Y-split, but she is much better than before. This is the pre-op and post-op. We were little bit conservative by doing medial rectus recession. I would have wanted to do at least 6, but I thought we would create some adduction limitation. So that's why you can see here a small deviation. And this is the last case where we have to remember, even if this is again an inverse Duane kind of situation with hypotropia. In this case, the inferior rectus cysticercosis responds very well to the treatment. And if you want to read more about this, we did a workshop at APOS, Surgical Management of Strabismus in Duane Syndrome, which will come in the next month, next edition of JAPOS. Thank you very much, and I would like to invite you to this conference in Barcelona, and following this, it could be in India. So it's free membership. All of us sitting here can contribute to this, and we can make a difference. Thank you so much.
Thank you, Dr. Ramesh.